Chapter 20 discusses disorders of hearing and vestibular function. So we'll start by talking about the structure of the ear, the external, middle, and inner ears. So the external ear is really kind of, the auricle, the ear canal, external acoustic meatus, everything kind of up until the tympanic membrane is considered the external ear. Its function is to capture, transmit, and amplify sound in addition to the functions of the middle ear. In the middle ear, you can see kind of demarcated here. It starts again at the tympanic membrane and includes the small bones in the middle ear as well, the incus, the malleus, and the stapes. So when we look inside the ear, we're looking through that auditory canal at the tympanic membrane, and then behind the tympanic membrane you can kind of see these sort of small bones that work to transmit and amplify sound. Finally, we have the inner ear, and that contains the receptive organs that are stimulated by sound waves, which is hearing, or things that are stimulated by your head position and movement, and those are its vestibular functions. So the inner ear has those two main functions. One is interpreting sound waves, and the other is head positioning and movement. So you can see that here. Here's the inner ear and the semicircular canals within the inner ear. Okay, and those connect directly to our cranial nerve 8 to transmit that information back to the body, both of vestibular positioning and of sound. So we'll start by talking about some of the disorders of the external ear. So just this portion prior to the tympanic membrane or eardrum. It can become impacted with cerumen. That becomes more likely as people age, and that cerumen starts to dry out and it can get kind of more stuck inside of that ear canal. We treat that simply by using maybe drops to soften up the cerumen and irrigating it out. But it can cause some level of kind of temporary hearing loss before that's cleared out. That can also, that portion can also become inflamed. We call that otitis externa or swimmer's ear, where we get kind of an infection of the ear canal itself. And we can also get drainage from the external ear. You can see that here, kind of this drainage. Otorrhea is what we call that. Treatment of these is either to reduce the inflammation or maybe with something like a topical steroid. And these things usually clear up kind of on their own. So we'll talk too about the basic functions of the eustachian tubes. So again, the eustachian tubes are kind of behind the tympanic membrane. And remember, the tympanic membrane is kind of where the middle ear starts. When we look inside of the ear, we can see the tympanic membrane. In a normal tympanic membrane, remember, it's kind of concave and like kind of pearly gray color. Pretty translucent, again, where you can kind of see those bones and things behind it. So that's what we would see in a normal tympanic membrane. Here it is, and it's connected again to those three kind of small bones that help to transmit sound waves to the inner ear. Those bones sit inside of a tympanic cavity that's directly behind the eardrum, and that cavity drains down into the eustachian tubes. Okay. So ventilation of the middle ear, along with equalization of middle ear and ambient pressure, is one of the major functions of the eustachian tubes. So again, acts to kind of equalize the pressure between the middle ear through the eustachian tubes. It also protects the middle ear from unwanted nasopharyngeal sound waves and secretions. So kind of having that space allows us to just transmit the sound waves we want and not sounds coming from the nasopharyngeal area, like when we kind of blow our nose or swallow. And so one of the things we sometimes see with people who have collections of fluid here is then we start to transmit sounds that we wouldn't normally hear when that is just a kind of open cavity. This area also serves to help drain the middle ear from secretions that come from the nasopharynx. So we do get secretions from the nasopharynx, but they should drain down through the eustachian tubes instead of accumulating here in the tympanic membrane. So we'll talk next about disorders of the middle ear and of the eustachian tubes, specifically things like otitis media. Acute otitis media, or an ear infection, is an acute bacterial or viral infection of the middle ear. It usually has an abrupt onset of signs and symptoms related to middle ear inflammation. So those are things like pain, temporary hearing loss. Those are relatively common with an acute onset of otitis media. We also have otitis media with effusion. This is the presence of fluid in the middle ear without signs and symptoms of acute ear infection. So sometimes people develop fluid accumulation behind the tympanic membrane in that kind of tympanic cavity. And it's not causing inflammation or pressure or pushing against the tympanic membrane. So there aren't those normal symptoms of kind of pain and pressure that we would get with acute otitis media. Usually caused by poor eustachian tube function and accompanied by a viral upper respiratory tract infection. These can often occur as a prelude or a sequela to acute otitis media. So sometimes people have an effusion that can then progress to an acute otitis media. Again, these are usually maybe a respiratory tract infection or just poor eustachian tube functioning. So the drainage that normally would go through the eustachian tubes to empty that tympanic cavity is interrupted in some way. So fluid starts to accumulate in that space, but it's not causing this inflammatory response that we see in acute otitis media. So risk factors for OM, so children between the ages of 3 months and 3 years are at much higher risk of developing otitis media. That's because their eustachian tubes at those ages are much shorter, and they're also more horizontal in layout. So they don't drain as well. You know, they're not kind of pointed downward to flow with gravity. It's easier for microorganisms to get trapped in there and to kind of travel back up to the tympanic membrane and cause infection and inflammation. So much more common in those age groups. Other risk factors, exposure to smoking in the household. Premature infants are at higher risk. Daycare attendance increases risk because of the increase in bacterial and viral infections that exist in those kind of close quarters. Not being immunized against some of our more common respiratory diseases can cause increased risk of otitis media. Bottle feeding also increases risk because of the way that kind of suckling motion on a bottle can sort of change the pressures inside of the ears, and it can prevent downward flow of fluid. Feeding also in the supine position. So when we're feeding infants, they should be sitting up to help reduce that pressure in the ear and to assist with eustachian drainage. And then also being overweight or obese can also increase risk. So the cause and clinical manifestations of acute otitis media. So again, usually a bacterial or viral infection that enters somewhere through the eustachian tubes. So RSV and influenza are common viral infections. So those would be things that risk could be reduced by immunization. Viruses are usually the initial cause, but they can also lead to a secondary proliferation of bacteria within the ear itself. And they usually follow an upper respiratory illness. So we'll see someone with an upper respiratory illness, usually viral in nature, that leads to otitis media. So the clinical manifestations are things like acute onset of otalgia, that's pain in the ear. And so infants, who can't report pain might be really pulling at their ear. It can often interfere with their sleep and activity as well. They might also develop a fever greater than 39 degrees Celsius. They can become irritable. There can be drainage coming out of the ear itself. They may experience hearing loss. You may see evidence of middle ear inflammation, especially on otoscopic examination. And you may see middle ear effusion, where you see decreased mobility of the tympanic membrane on otoscopic examination. So diagnosis and treatment, one big thing to emphasize is the importance to distinguish between acute otitis media and just effusion, okay? It's important to distinguish because of associated antibiotic resistance that's occurring with overtreatment of ear infections. So OME usually just kind of resolves on its own, and if it's not causing inflammation, pain, or any other symptoms, it typically doesn't need antibiotic treatment. But if there's significant signs and symptoms of ear infection or inflammation or break in the tympanic membrane that we see maybe with acute otitis media, then we can consider antibiotic use for those. But we really want to be conservative about our antibiotic use and not use it for conditions of the middle ear that could resolve on their own and aren't causing significant pain or damage to the ear itself. So looking also at things like a history of acute onset of signs and symptoms, that would be more indicative of AOM than OME. We also look for the presence of middle ear effusion, and that can be confirmed by a bulging tympanic membrane, limited or absent movement of pneumatic otoscopy, or seeing kind of air or fluid levels behind the tympanic membrane, or drainage from the tympanic membrane itself. And we'll also see usually erythema or redness of the tympanic membrane at onset of pain. So those are some, again, things that are acute signs. So treatment for acute otitis media is usually either waiting it out if the inflammation isn't too severe. Sometimes we don't use antibiotics in those cases. Sometimes we can just do conservative treatment with maybe pain medication. But in more severe cases, we can use antibiotics. But again, they are of no benefit in cases of OME. And we'll talk about disorders of the inner ear. So the inner ear is composed of these intricate channels that facilitate things like hearing and position sense. One of the disorders of the inner ear is something called tinnitus or tinnitus, depending on how you say it. This is a perception of abnormal ear or head noises not produced by an external stimulus. So you get this kind of constant ringing or buzzing inside of the ear when there's no external stimulus. So the entire stimulus for that sound is coming from the inner ear itself. But the major disorder that we see of the inner ear is hearing loss. Hearing loss can be either mild, moderate, severe, or profound. And there are two types. One is conductive hearing loss, and that's where stimuli aren't being adequately transmitted. And so that's typically hearing loss that occurs in the outer or middle ear, where we have that kind of movement and transition and transmission of sound itself. So maybe damage to the tympanic membrane, maybe damage to the small bones in the middle ear, maybe cerumen impaction in the ear canal that blocks transmission of sound, okay? We'll contrast that to sensorineural hearing loss, and these are disorders that affect the inner ear, the auditory nerve, or auditory pathways of the brain. So these can be things like noise-induced hearing loss, presbycusis, which is sensorineural hearing loss that occurs with aging, hypertension, atherosclerosis, head injury, and cochlear or labyrinthian infection or inflammation are all things that can cause or predispose people to sensorineural hearing loss. Okay. You can also get mixed hearing loss where you have both causes that are leading to the loss of hearing. So we're going to start by talking about conductive hearing loss. Again, it's things that can be in the external ear, like impacted earwax or a foreign body, or it can be caused by otitis externa, where we have that inflammation that causes like kind of maybe a severe, like kind of swelling and closure of the ear canal itself. And then also by middle ear conditions. So maybe trauma to the head that might damage maybe the tympanic membrane or those small bones. It can be caused by otitis media, either acute or with effusion. It can also be caused by what we call otosclerosis, where those kind of small bones inside of the middle ear start to sclerose and don't transmit sound as readily. And also tumors of the middle ear can also occur. Sensorineural hearing loss can be caused by, again, trauma, so things like head injury, or the kind of chronic trauma that occurs with exposure to loud noises. It can be caused by central nervous system infections like meningitis that can infiltrate the acoustic nerve itself, leading to interruptions in sound transmission. It can be caused by degenerative conditions like presbycusis that we see in aging. It can be caused by vascular conditions that reduce blood flow to the inner ear, like atherosclerosis. If there is sudden loss of blood flow, it can cause kind of a sudden deafness as that ischemia damages the inner ear. It can also be caused by some of our ototoxic drugs, like your aminoglycosides, salicylates, and some of our loop diuretics. There are tumors that can infiltrate the vestibular schwannoma, that's part of the inner ear itself. That's a tumor called an acoustic neuroma. There are also meningiomas that attack the acoustic nerve itself, the meninges of it, or metastatic tumors coming from other locations can manifest themselves in areas of the inner ear. And there's also an idiopathic form of sensorineural hearing loss that we'll talk about called Meniere's disease. Sensorineural hearing losses are usually irreversible forms, unlike some of the conductive hearing loss that we could maybe take away, right, the underlying cause and improve the condition. These sensorineural changes are usually permanent. So some treatments for hearing loss. If it's an external ear issue, we could do things that are as simple as removing the impacted cerumen. We can also use hearing aids. Those are common in maybe age-related presbycusis, where there's this kind of slow progressive loss of hearing. So a hearing aid may help by sort of helping to amplify sound to counteract the effects of that hearing loss. Cochlear implants can be used for people with profound levels of deafness to sort of replace the functions of the inner ear or the cochlea. We can also do reconstruction, surgical reconstruction of the tympanic membrane if that's the cause of hearing loss. One note about some special considerations in children. Even slight or unilateral hearing loss can really negatively impact a young child's language development. So it is really important to screen young children for the signs and symptoms of even minimal hearing loss to prevent, and then to treat them to prevent any changes to language development that may occur as a result. We do have a lot of balance reflexes within the inner ear, and this function is needed for proper balance as well as keeping our upright posture. So within the inner ear is something called the vestibular nuclei, and it is the integrative center for balance. And it receives input from both visual and somatic receptors. We also have cranial nerves 3, 4, and 6. Those pick up reflex movements from the neck and from the limb. And then we have the vestibulo-ocular reflexes, and those help to balance the muscles of our trunk. So if we get disorders of vestibular function, we can develop disorders of balance. So vertigo is an illusion of motion. So you feel like you're in motion even when you're at rest. So the person may be stationary and the environment feels like it's in motion. That's objective vertigo. Or the person may be in motion and the environment seems stationary. That's subjective vertigo. Vertigo, because of peripheral vestibular disorders, tends to be severe in intensity and episodic in duration. We contrast that to vertigo that's caused by central vestibular causes. Those tend to be a little more mild and more constant and chronic. Another disorder of vestibular function is motion sickness. This is a form of normal physiologic vertigo, and it's caused by repeated rhythmic stimulation of the vestibular system, such as encountered when we're in a car, or in the air, or sometimes with boat travel that makes someone feel kind of nauseous, dizzy, and lose their balance. So disorders of peripheral vestibular function. The peripheral vestibular system consists of a set of paired inner ear sensory organs that send messages to the brain centers, and then the brain center interpret those signals related to our body's position in space, as well as the control of a movement of our eyes. So we have what we call benign paroxysmal positional vertigo, where these signals that are normally transmitted are distorted. So patients with this disorder get this sudden onset of dizziness and vertigo that's provoked by certain changes in their head position. So if they change their head position kind of suddenly, they get this sudden onset of dizziness and vertigo. And this is being caused by damage to the delicate sensory organs within the inner ear itself. The other disorder is something called Meniere's disease, where the signals that are normally transmitted are unbalanced by unilateral involvement of one of the vestibular organs. So these patients get kind of a triad of symptoms. They get fluctuating episodes of tinnitus or ringing in the ear. Their ears kind of get this feeling of fullness, and they also get violent rotary vertigo that often renders them unable to sit or walk. So it's very severe vertigo where they may have to even lie down. They have severe balance issues. They can be at a severe risk of injury because they can kind of lose their balance suddenly and fall. Meniere's disease has several possible causes. It can be caused by trauma to the ear, to the head. It can also be caused by infections like syphilis. It may be an immunologic cause where there's inflammation that causes damage to the inner ear. It can be caused by endocrine dysfunction like adrenal or pituitary insufficiency or hypothyroidism. And it can also be caused by vascular disorders that interrupt blood flow to the inner ear.